mainly the arteries. So they will rupture at some stage or the other unless we're going to treat that. Okay, so I'll just give you a case scenario to begin with. This is a patient, a 80-year-old male, chronic smoker, presented to surgical casualty unit with sudden onset of lower abdominal pain. He also complained of back pain, which is there for about 3 hours. He had associated fainting episode. He is also known to have chronic obstructive pulmonary disease, COPD, hypertension, ischemic heart disease, and he has a echo finding, echocardic finding of ejection fraction 45. So on admission, his extremities were cold, and blood pressure was 100 by 50 millimeter mercury. Heart rate is 100 per minute. So that means that he's having some sort of pulmonary stability, and respiratory rate was 22. Abdomen revealed tender pulsatile epigastric mass. Okay, so this is the typical kind of a history you would expect in a patient who had got an aneurysm, which has probably ruptured. Hello?
Yes, sir, we can hear.
Okay. So, you know this guy? You? Who is this?
Albert Einstein.
Yes. He has this famous equation. So, the story I brought him here is because the tragic thing happened to him. He had an aortic aneurysm. And in 1948, there was a famous surgeon by the time, this Ralph Nissen. You might have heard some called Nissen funduplication in the stomach. So this is the same chap, Rudolph. He was a famous surgeon. He wrapped cellophane, it's a plastic, around the Einstein's aneurysm in order to prevent rupture. So, and also to limit the expansion of the aneurysm. But eventually, in about another 7 years down the line, it ruptured spontaneously. And Einstein, by the time, realized that he was not going to make anything more, and he didn't want to have any other operation done. So he just said, "Let me settle in peace." So he died of ruptured aortic aneurysm. Okay, so you can imagine the type of operations that was carried out a long time ago. Not so long time, but 50, 75 years ago. And so this is how the aneurysm is looking like. When you open up in the right-hand corner, you see the balloon blood vessel. This is aorta, abdominal aorta. On the left-hand side, you need to do a CT scan. That is a scan we do in CT by use of CT machine. So this is Hello. You all hear me now?
Yes, sir.
Okay. So there's problem with the internet because there's maybe rain here. Okay. Let's continue. What did you all hear? I don't know where I missed it. Let's see. Did you all hear this part? Hello? Hello?
No, sir, it was before that.
At this time?
Yes, that.
This slide? Okay. Right. One after the other.
Slide number
This
8,
one?
sir.
CT angiogram, sir.
All right. CT you saw. This one. Okay. So this is showing how we repair the aneurysms. Yeah. So we open up the blood vessels and we open up the abdomen. We see we dissect that segment and they put a plastic tube in. So it's not actually plastic. It is made of fabric. We put it to end to make it patent, to maintain up and down to its artificial tube. So this is what I'll explain it later on, but just want to have some glimpse of what we are doing when you operate on aneurysms. Okay, so basically these are the sites where you can get aneurysms. So this is a description of the blood vessels in the body. The IBC, that's the aorta on the right or left side. You see so normally the aneurysms do occur in particular areas in your body. So abdominal aorta is more prone to develop aneurysms. Whereas iliac arteries, common iliac arteries are next in common. And then you get the popliteal artery, which is the third in order. So these are the three sites where you get aneurysms, normal. But apart from that, you can get aneurysms in thoracic aorta and real in the radial arteries and the pedal arteries where. Okay? You all follow me? I'm not sure whether they are or not. Okay, right. Right. So let's get into the definition of the aneurysm. So it is actually abnormal focal dilatation of the blood vessels. Why I call blood vessel all the time is because it can happen in veins as well, but mainly happen in arteries. We call aneurysm when it is more than 50 times or 50% increase in diameter compared to the adjacent area or segment of the vessel. So more than 1.5 times increase in diameter. So if you take the aorta, for example, the diameter is normally in adults about 2 centimeters, but when it reaches about 3 centimeters only for aneurysm. So what happens in between those 2 and 3 centimeters, in between 2 and 3, it's again enlarged, but it's not aneurysm. You don't call it as aneurysm, but that's a different terminological ectasia. Basically dilation, but not as to the diameter as we call it aneurysm. So there's a different condition called arteriomegaly. If there is a diffuse continuous enlargement of multiple segments of the blood vessel, we call it arteriomegaly. So it's not truly an aneurysm, because aneurysm, it has to be focal. If there's diffuse, you don't call it aneurysm, it's called arteriomegaly. And there's other condition called aneurysmosis, because there are multiple aneurysms in several segments of the anatomical segments of the body. So that's aneurysmosis. So these different nomenclatures. you just get familiar with these things. So just to give you some brief outline or more into the picture of this aneurysm and ectasia. So the diameter is more than 50% normal external diameter is called aneurysm, ectasia less than that. So the primary problem with this aneurysm is that when it enlarged to a certain diameter, it can no longer sustain the blood within it, because you know what happened to a balloon when you inflate, it will rupture, isn't it? It will burst. The same thing happens to the blood vessels. When it enlarges to a certain level, limit, it ruptures. It leads to catastrophic hemorrhage, and that can lead to death, obviously. And so the risk of rupture actually is related to both the absolute size of the aneurysm as well as its relative to the normal diameter, and also depend on the bone specific location, body size, and the gender. Because if you take, for example, in male, heart, I said is the 3 centimeter diameter when it's called aneurysm. The rupture risk is significantly large. It's getting worse. And before that, the rupture risk is minimal. But in ladies, female, you don't wait until it's 5.5 centimeters. It may be around 4 centimeters, 5 centimeters, it will rupture. Sometimes small male people, the aorta may not be that big. Maybe 1 centimeter. So in that sense, you don't wait until that get that bigger. So that,
Excuse me, sir.
I said, yeah.
No, it's not recording.
Yes. You hear me?
Sir, it's not
How?
recording. Can you restart the recording, sir?
Okay. Yes, sure.
Thank you, sir.
Okay. Right. Okay. So, this is the classification of aneurysm. So, there are things called true aneurysm and false aneurysm. Why called true aneurysm? This is actually made of 3 layers of the blood vessel. You know, the blood vessel are media and adventitia. The adventitia is the outermost layer, and it is the toughest layer. The media contains air that maintains the homeostasis of the blood, prevention of coagulation, and the diuretic system. They all these about intima. Anyway, so but the aneurysms, true aneurysm, contains all 3 layers. So when the balloon enlarges, you know, as the wall get enlarged. So that's likewise the vessel wall, when it get enlarged, the 2 wall get enlarged. There's something called false aneurysm. False means there's no actual good layer. This layer is actually made of fibrous tissue. I'll elaborate on this later on. And then about the morphology. Morphologically also, you can have 2 forms, like fusiform or the acicular. Fusiform or circular, I'll show you later. And by etiology also, you can describe as whether it's atheromatous aneurysm or any mycotic aneurysm. Because mycotic more to the fungi, not so. The bacteria, fungi, or whatever, infective pathology is causing the aneurysm. That's mycotic. And it can sometimes happen due to collagen disease, or sometimes can happen due to trauma. So this is what I told before. So you can see false aneurysm is like this. It has only the outermost layer, or sometimes only the fibrous tissue, and it is actually retained by the fibrous tissue made of hematoma. So when the blood get extravasated due to a gap in between a vessel, so that leads to blood extravasation. That blood goes to the surrounding tissues, and the surrounding tissue get expanded. So there's no true wall in that. So that's called false aneurysm. Problem with this false aneurysm is it can rupture at any time, because it can rupture very easily because there's no retention wall. Okay. This is how it looks like. This false aneurysm that's like a sac. Not actually a kind of a different morphology compared to saccular, the fusiform. Sorry. So this is how it appears when you open up. You can see a hole in the artery, and you actually image it by a scan. You can see the colors within that. Okay. So this is actually on the right hand side. You see the fusiform aneurysm, and on the left side, the saccular aneurysm. It's the next sac. Basically, the false aneurysms are saccular, whereas true aneurysms are fusiform in nature. All right. Are you all with me? I think my internet connection is not that stable. You all hear me?
Yes.
Okay. So this is in dark kinetic mode. So you can see the fusiform, and this is more saccular. Only from one side is enlarged. So it's saccular. So from an anatomical point of view, so the femoral artery is more vulnerable to get something called pseudaneurysm. It's because nowadays we do a lot of percutaneous interventions for coronary heart disease. We have heard putting a lot of stents into the coronary arteries. This is the usual access site where we gain access to the blood vessel in order to get into the coronary arteries. So we puncture the femoral artery and get into the coronary artery. That's how we do by use of guide wires and a lot of other gadgets. So the femoral artery, once it's ruptured and form into usually it has to seal on its own once we take out the wires and everything out. But sometimes it will not. That leads to pseudaneurysm. Femoral pseudaneurysm are some of the known things nowadays. That's called iatrogenic because it's used by surgeons or the physicians. So iatrogenic. And can happen due to trauma. Nowadays, for traffic accidents like motorcycle injuries that can lead to ruptured blood vessels. Sometimes it can form something like this. It's damaged, but still they are maintain the patterns. So that's all pseudaneurysm formation due to trauma. Right. So you can describe about the aneurysms depending on location, like aortic, iliac, popliteal, femoral. This way, we form an iliac, femoral, popliteal. So this is just to show how it expands. When there's pseudaneurysm, during systole, the blood goes inside the sac, then it rotates, and then it comes back. So this is how it happens, but due to the pressure, it keeps on expanding. That's what happens. One is another lecture that I have You all see this? Hello? Hello? You all follow me? Hello?
Hello, sir. We can see.
You all see this? My screen? You all see that, is it? Okay. So let's talk about risk factors for the development of aneurysms. Yeah. So advanced age is the most common reason for it to develop aneurysm. What I call advanced is not 40s. It's first, and male gender is more prone to develop aneurysm. If you do smoke, you have high chance of developing aneurysm. And hypertension is the other factor it leads to this. There are connective disorders like Marfan's, Ehlers-Danlos, or other connective diseases that leads to inherent weakening of the vessel wall and lead to the aneurysms. Patients with obesity also predisposes to aneurysm. And strangely, diabetes has a negative risk factor. Those who have diabetes having less chance of developing aneurysm. Okay. So if we talk about reasons why thing is because there's atherosclerosis that will lead to weakening of the vessel wall and leads to the occlusion of the blood vessel. But the same patient have dilatation of the vessel due to weakening. Because atherosclerosis is a degenerative condition, and there's some bit of inflammation also going on that leads to the destruction of the vessel wall. And trauma is another cause I talked about previously. Infection like tuberculosis, like the infective microorganisms, like syphilis, they all cause aneurysm, and collagen disease and all, etc. Right. There are these developmental or congenital anomalies which are associated with persistent sciatic cut. These are very uncommon reasons. I just want to mention here just for sake of completion. I don't have memorized, so just like to go and understand this. Okay, but you will learn these things later in your life. Okay? So infections, I told you this TB and syphilis are the common reasons, and okay. So what do you do as investigations when you do have aneurysm? You might do a scan, the simple ultrasound scan, and that will show us the balloon blood vessel. But if you talk about the abdomen, ultrasound will not show it very well because problem with ultrasound is that it has to go to the bowels. The bowel contains air, and you will not be able to visualize it very well. But it's good in peripheral regions like limbs. You can see it very well. So ultrasound has less sensitivity in detecting the aneurysm. But you want to take more morphological description about the aneurysm. You have to go by the CT scan. That's called CT angiogram. You inject the contrast into your peripheral vein and then visualize the artery, the arterial phase, and then you can actually get cut sections, and you can amalgamate these cut sections and reconstruct the computer, and that gives a nice picture of your blood vessel. So MR also is very helpful, but problem with MRI is MR angiogram is that it's time consuming. It takes about at least half an hour for you to get a proper image of the MRI scan. So, whereas if you take CT, within 2-3 minutes you can take all the pictures. Is that clear? Are you following me? Hello, are you following me? Hello. Hello. You all have to speak, otherwise I don't know whether you are
With the connection, sir, can't hear clearly.